Good morning everyone. Myself Dr. Shantanu Prakash Agarwal, Scientific Secretary, GK Association. We have gathered here today as a part of our regular morning CMEs. The topic for today is updates on vertigo. As you all know, it is a very common clinical condition faced by all of us in our regular day-to-day practice. So, to gain more and more knowledge and in-depth knowledge, we have kept the topic, this update on vertigo, and I would like to invite Dr. Anurag Kumar SIngh to enlighten us in detail. Thank you.
As we all know, in our day-to-day practice, this is a very common topic. Patient present with different symptoms like vertigo, imbalance, dizziness. So a brief review would be done to differentiate what is actual vertigo and what is meaning of dizziness, and how to manage all these cases. Dizziness. What is dizziness? Dizziness is the third most common complaint among all the outpatients we see. It is the single most common complaint among patients older than 75 years of age. We all see that old age patient greater than 75, whether they have a difficulty in walking, imbalance, they all complain of dizziness, most of the patients. And patient describe this dizziness in various terms like giddiness, lightheadedness, faintness, vertigo, fogginess, imbalance, unsteadiness, and ataxia. Patient often comes to our OPDs that chakkar. In Hindi they means chakkar. Chakkar is a broad term which includes, it may be vertigo, it may be imbalance, it may be unsteadiness, difficulty in walking, or lightheadedness. So this is a broad term. And it's very important to differentiate what is true vertigo and what is other causes like lightheadedness, giddiness, which includes in this. And of all the cases of dizziness, true vertigo accounts for 54% of the cases. What are the common type of dizziness present to us in our OPD practices? First one is true vertigo. What's the meaning of true vertigo? That the sense of spinning or rotation. Patient tells that all the things are rotating or my body is rotating. So this is true vertigo. And how it's provoked by head movements most of the time. And the root cause is vestibular system. It may be peripheral vestibular system and central vestibular system, as we have read in our MBBS. Faintness. Second most common is faintness due to cardiovascular disorder. Suppose the blood pressure is low, so patient may have symptoms of blackouts. They tell that andhera chha ja raha hai chalne pe. So that is faintness. This is also pre-syncope symptoms, and they also tell in a broad way. They also term this term as dizziness. We have to differentiate whether it is true vertigo or faintness. Third is imbalance. This is also very common. Patient tells us whenever I walk, I have a difficulty in falling or I would lose my balance. Causes are neurological disorders, and we have to carefully evaluate what are the causes of this imbalance. So patient tells that whenever I walk, I keep foot here and it goes there. So they also describe this word as dizziness or chakkar. But we have to clarify that what is the meaning of this chakkar they are telling about. This is true vertigo, this is faintness, this is imbalance. And fourth one is very common, psychogenic. Psychogenic patients such as they describe as lightheadedness. Sir halka rehta hai, and a mild form of type 1, type 2 and type 3 may appear as type 4. Ruling out earlier type is important. Whenever patient tells that sense of chakkar, and we have ruled out true vertigo, faintness, imbalance, all the other organic causes, Psychogenic causes are also included. What are the causes of true vertigo? Most common is benign paroxysmal positional vertigo. It is the most common cause of vertigo, true vertigo. Other are Meniere's disease, vestibular neuritis, migrainous vertigo, which is known as vestibular migraine, and CNS dysfunction, such as stroke, MS or tumor. A patient with stroke, multiple sclerosis, tumors, migraine patients due to vestibular neuritis, Meniere's, all may present with, these are true vertigo, all may present with vertigo. Second is faintness. Faintness is orthostatic due to orthostatic hypotension. Suppose the blood pressure is lower, so faintness or presyncopal symptoms may appear. The patient may present that whenever I stand, blackouts, अंधेरा छा जाता है खड़े होने पे. So we have to evaluate the orthostatic supine and erect blood pressure, and we have to clarify or rule out orthostatic hypotension. Third one is imbalance. Imbalance is very common, in older age group. It may be due to Parkinson disease, peripheral neuropathy, or white matter diseases of the brain, stroke. All may present with imbalance, which is one type of dizziness. And fourth one is psychogenic patient are anxious, hyperventilating. They also describe the term as dizziness or chakkar. So we have to clarify what is true vertigo. This is faintness, imbalance, or after ruling all out psychogenic causes. What is the true definition of vertigo? The sensation of motion when no motion is occurring relative to the Earth's gravity. Patient tells that चक्कर आ रहा है, सारी चीज़ें घूम रही हैं, बट एक्चुअल में कुछ नहीं घूम रहा होता है. तो पेशेंट अपने वर्ड्स में डिस्क्राइब करेगा कि ऑल द थिंग्स आर रोटेटिंग और मैं खुद घूम रहा हूँ. तो हमें एक्चुअल में ऐसा कुछ रोटेशन वास्तव में नहीं है. तो दिस इज द ट्रू वर्टाइगो. It's a feeling of movement, a sensation as if the external world were revolving around the patient, objective vertigo, or as if he himself were revolving in space, subjective vertigo. In the objective vertigo, patient tells that सारी चीज़ें मेरे आसपास की घूम रही हैं, दीवार, खिड़की और टीवी. एंड इन द सब्जेक्टिव वर्टाइगो पेशेंट टेल्स दैट वो खुद घूम रहा है, उसको ऐसा एहसास हो रहा है कि उसकी बॉडी खुद ही स्पिन कर रही है. सो these are two objective and subjective vertigo. Epidemiology, in a brief, in adults is 18 to 79 years, prevalence is 7.4%. The 1 year prevalence is 4.9% and 1 year incidence is 1.4%. Female preponderance is observed among individuals with vertigo. 1 year prevalence ratio for male to female is 1.2 to 1.2 by 1 by 2.7, sorry. And 3 times more frequent in the elderly as compared to young. We all see that the symptoms of vertigo is found in young, but it is very common as the age advances, because due to BPPV or other causes increases with age. What's the impact? It's highly impact any one person's life. Whenever a patient or we suffer from vertigo, it's a very disturbing. It affects. It has a chances of recurrence in 88% of the affected patients. Daily life is affected. Day-to-day work is affected. 80% of the patients. Quality of life is reduced whenever patient has vertigo. He cannot do his routine work normally. Some psychiatric disturbance due to this problem also occurs due to feeling of vertigo. Sick leaves and frequent medical consultations, and the elderly falls. So it has a highly impact in our day-to-day life. So understanding this topic and clarifying and treating this is very important for patient's improvement. This is a brief anatomy we have read in our MBBS, that the 3 canals and 2 otholates in each ear, semicircular canals, saccule and utricles, which are the part of vestibular system. Includes vestibular nerve, which carries signal to the vestibular nuclei. This is the semicircular canals, 3 semicircular canals. This is the vestibular nerve attached, and it is going to attach with the vestibular nuclei. Otoliths sense linear acceleration, and semicircular canal sense head rotation. So these are the system which is responsible for vertigo, and the sensation of rotation or linear accelerations are included in this in the form of otoliths. This is a brief anatomy as we have discussed. This is a peripheral vestibular system. This is the vestibular nerve attached to the brainstem. So central causes of vertigo are included in this, and peripheral causes are included in this peripheral vestibular. Diagnosis of vertigo. Specific diagnosis is rare in patient with vertigo seen in general practice. Misdiagnosis is very common because we often see that patient describe chakkar, and if we properly not evaluate, we prescribe beta-histine or any other type of vertigo, which is not good. We should first of all evaluate what is the meaning of his chakkar. That is, it is a true vertigo, sense of spinning rotation, or whether it is imbalance, whether it is faintness. In a study of 3,400 patients over 70 years of age, an accurate diagnosis was possible in more than 75%. A brief bedside examination should be done for 2 minutes, 3 minutes time takes. Includes eyes for nystagmus, ears, cardiovascular system, nervous system and vestibular system for the evaluation of dizziness. And proper history and good clinical examination can provide a diagnosis in the majority of patients. So we should give 2 minutes times to evaluate the eyes for nystagmus, ears examination, cardiovascular system examination. What should be the approach to a dizzy patient? An algorithm clinical approach is always useful in arriving at a diagnosis with least diagnostic tests. So clinical examination is very important, and a set of questions should be asked to differentiate various causes of true vertigo when a patient comes to us with the complaint of vertigo. What are the set of questions that should be included? First, what's your onset time, course and length of attacks? How much the duration of the vertigo, when it started, and how much it took time to go away. All the patients should be asked about the head motion, whether the head motion incite or aggravate the vertigo. Are there any associated cochlear symptoms such as hearing loss, tinnitus or a spatial sensation of oral fullness? Because for Meniere's disease and vestibular neuritis, vestibular labyrinthitis, this should be asked to differentiate auricular causes of vertigo. Are these exaggerated when the dizziness is worse, when the symptoms are aggravated? Was there any antecedent head injury, pressure changes or symptom of a viral syndrome? Because viral syndrome may occur before vestibular neuritis or labyrinthitis. Head injury provoke BPPV, we commonly see positional vertigo aggravates. Whether it's associated with headache or not, because association with headache is common in vestibular migraine, so headache history should be evaluated. Are there any neurological symptoms? Because 25% of true vertigo are central vertigo, so gait disturbances and any dysarthria, this should be any other focal neurological deficit should be asked. Many drugs can provoke vertigo, so drug history is important, such as aminoglycoside antibiotics and other group of drugs. can provoke vertigo, dizziness. How the vertigo is classified? Whenever patient comes to with symptoms of vertigo, we should ask whether it's a single episode or recurrent attacks. Recurrent attacks, if he says single episode, we should note, and if the recurrent, whether it's with hearing loss or without hearing loss. These are the common causes of vertigo. The most common is BPPV, benign positional vertigo, paroxysmal. Recurrent, the time course is important. The duration of the vertigo is seconds to minutes. It's not much more than 2 to 3 minutes usually seconds to minutes, and it's recurrent. Patient tells that today I have 10 times vertigo, each lasting for 1 to 2 minutes or 30 seconds, but it's recurrent. In between the attacks, patient is better, but whenever he changes the head position, it again aggravates. History, brief triggered by head movements. BPV most of the time triggered by head movements. And nystagmus is upbeating, torsional, and the gait is normal in between the attacks. No auditory symptoms are found, and Dick-Salpipe maneuver is done to evaluate BPV, to check for BPV. We would see the Dick-Salpipe in the next slides. How the patient of vestibular neuritis will present? They have a single episode lasting days. Continuous vertigo, they tell that for 2 days I have continuous 24 hours vertigo. And the vertigo is subacute onset, severe, constant vertigo with significant nausea and vomiting is there. If the patient has so much nausea and vomiting and continuous vertigo. And when we see the nystagmus is found horizontal or horizontal torsional, and gait, patient towards the affected side, they would sway away. And hearing loss is found if there is labyrinthitis associated with vestibular neuritis. Labyrinth is affected. And how we test? Positive head thrust test, nystagmus suppressed by visual fixation. Vestibular migraine, it's a recurrent lasting minutes to days. It's also recurrent vertigo. And a previous history of migraine, vertigo accompanied by migrainous symptoms is there. Nystagmus is usually not present in vestibular migraine. So patient with vestibular migraine have a history of headache, and vertigo may be accompanied by migraine symptoms. Gait is abnormal during the vertigo attacks, and there is no auditory symptoms. Diagnostic findings, vertigo attacks resolve with acute migraine medication. So the same medication which are given for migraine would resolve the vestibular migraine. And Meniere's disease, it's recurrent lasting hours duration of vertigo is recurrent lasting hours, and history of hearing loss, tinnitus and earfulness. So patient often gives in Meniere's disease that whenever this vertigo is present, they have also feeling of tinnitus, earfulness and hearing loss. If you evaluate for the nystagmus, it's horizontal or horizontal torsional found during the attacks of vertigo. These patients may have impaired gait and balance due to vertigo whenever there is an episode is there, and auditory symptoms are present. And diagnostic audiometry is done to find fluctuating low frequency hearing loss. So these are the common causes of peripheral vertigo, BPPV, vestibular neuritis, vestibular migraine, Meniere's disease. Whenever a patient comes to us in OPD, we should evaluate, these are included in the differentials. Duration of vertigo is important. A few seconds, if a vertigo is of few seconds, What are the causes? Peripheral causes such as unilateral loss of vestibular function in late stage of vestibular neuritis, late stage of menial disease, few seconds, and several seconds to a few minutes. This is BPV, perilymphatic fistula. This is very common, and several minutes to 1 hour. If the patient tells that duration of vertigo is several minutes to 1 hour, posterior transient ischemic attacks, perilymphatic fistula is there. Hours. If the patient tells that no, I have vertigo which is lasting for hours, घंटों तक मेरा चक्कर लगातार आता रहता है, तो in this case, Meniere's disease, perilymphatic fistula from trauma or surgery, migraine and acoustic neuroma is suspected because they have long duration vertigo. And if patient tells that I have vertigo for days, it's continuous vertigo, non-resolving, continuous through days. मेरे को 3 दिन से लगातार चक्कर आ रहा है, continuous. So this is differential include vestibular neuritis, stroke, migraine and multiple sclerosis. And weeks. Most of the causes of vertigo are in days, but when we also see some patient tell that for 6 महीने से लगातार मुझे चक्कर ही आ रहा है. So constant vertigo lasting week without improvement, you give vestibular suppressant drugs or another, they do not respond, and all the organic causes are ruled out. So this differential includes psychogenic cause, and this should be evaluated accordingly. Most important is differentiate when central from peripheral causes of vertigo. This is a feature which is important to differentiate peripheral and central vertigo. 4-5 important feature by which we can easily differentiate peripheral and central vertigo. The direction of nystagmus. In the peripheral vertigo, the direction is fast phase opposite towards the lesion. Suppose the patient has right-sided vestibular neuritis. So due to right-sided vestibular, so fast component would be towards the common left side because the right side is not working. So left will dominate and the fast component would towards the left side, nystagmus. While in central, this is bidirectional, both the sides are unidirectional. Pure horizontal without nystagmus without torsional component is very uncommon in peripheral vertigo, and it's very common in central vertigo. Means the nystagmus is horizontal without any torsional components, favors for central vertigo. Vertical or torsional or purely torsional nystagmus is present in central vertigo, but it's never present in peripheral vertigo. We all know that visual fixation. Whenever we fixate in peripheral vertigo, the nystagmus is suppressed, while in central vertigo, it is not suppressed. It's severity of vertigo. This is very important. Whenever a vertigo is severe, it's most of the time it is peripheral, and in the central vertigo the intensity is not so severe. Patient with peripheral vertigo has severe vertigo, nausea, vomiting, so more favor of peripheral vertigo. Direction of the spin towards the fast phase in peripheral vertigo, and it's variable in central vertigo, and direction of falls towards the slow phase in peripheral and variable in peripheral. Central vertigo may be chronic, while the peripheral vertigo is usually minutes, days to weeks, but it may have a recurrence chance. Tinnitus deafness is usually present in peripheral vertigo and usually absent in central vertigo. Associated central nervous system abnormalities are uncommon in peripheral vertigo, and they are very common, such as double vision, hiccups, cranial neuropathies, dysarthria in central vertigo. And the common causes of peripheral vertigo are BPPV, labyrinthitis, vestibular neuritis, Meniere's, neuronitis, ischemia, trauma, toxin. While vascular causes such as stroke, demyelinating lesion in the brain, or neoplasm are responsible for central vertigo. So after distinguishing central and peripheral causes, a brief review of central vertigo. The 25% of the vertigo have central causes. Incidence is higher in elderly, and ataxia is the most useful sign for diagnosis of cerebral pathology. And etiological target management is acceptable. Hospital admission for patients suspected of central vertigo is advised. In the central vertigo, most common is stroke, because whenever the brainstem stroke is there, patient may have central vertigo and the gait disturbance is there, so proper examination should be done. Gait should be checked, and dysarthria, diplopia, all should be checked to evaluate for the central causes. And it's very common in elderly, especially diabetic hypertension. Neuroimaging in patient with neurologic sign and symptoms, neuroimaging should be done, such as patient has hypertension, diabetes, history of smoking, is greater than 65, prior history of atherosclerotic vascular diseases, and progressive unilateral hearing loss, such as this is common in acoustic neuroma, and hypertension, diabetes, is greater than 65, risk factor for stroke, chances of stroke are there, so we should done neuroimaging in this type of patient. Now comes at the last for the vertigo management. What should be the approach for the management of vertigo? Just diagnosis, not merely suppress the symptoms. Restore normalcy to deranged balanced function by promoting vestibular compensation through physical therapy. Improve the neuronal metabolism, cognition, and correct any concomitant psychological disorder, and provide symptomatic relief for anti-vertigo and MTMT. So whenever patient comes with vertigo, the proper symptom removal is necessary, along with curing of the disease, resolving all the basic problems, such as neuronitis is there, so steroids should be given, BPPV exercises, vestibular rehabilitation exercises should be advised. So not just prescribing the medication is enough. We have to evaluate Meniere's disease is there, so accordingly we have to give diuretics and all the things. What are the principles of management? Whenever patient comes to a vertigo, we have to give empathy and reassurance that most of the time it cures. Rehabilitation exercises should be advised in proper patients, and pharmacotherapy should be started, which is necessary, and surgery is reserved in very few cases of Meniere's disease or acoustic neuroma. As we commonly see, when a patient comes with vertigo, they are very anxious, they are very anxiety conditions. So alleviate their anxiety by explaining the cause of vertigo and nature of the disorder. And positive counseling should be done. Whenever patient comes with vertigo, we should reassure that suppose if you have diagnosed BPPV, initial 2-3 days are severe vertigo present in this, so we should assure that don't worry, with the time it would go away, and with the treatment most of the time it cures. Very important thing which should be done in our day-to-day practice is rehabilitation, and it's a form of physical therapy recommended for vertigo, which uses specialized exercises to gain gaze and gait stabilization. singly or in combination with pharmacological treatment has been proved useful for managing vestibular or central balance dysfunction. So rehabilitation are very common treatment in vertigo, such as BPPV. So rehabilitation exercises are there, such as Apley maneuver, Bendorf exercises, so that the semicircular otoliths can be properly come in their natural position and vertigo can be finished. In BPPV, canal repositioning maneuver is the mainstay of management of BPV, such as Apley maneuver, Bendorf exercises, leg roll exercise. So this should be advised, because if we not advise, the vertigo has a chance of recurrence, and it would go prolonged duration of vertigo, take 1 to 2 months without this. This is a Dick's Hell pipe test, which can be done very easily in OPD. 45-degree turns the head, and then behind the couch, rotate the head to 45-degree and 30-degree inclined. And both sides, whenever we do in this position, if the nystagmus is present, after waiting 30 seconds, this suggests that BPPV, benign positional vertigo. We have to done in both sides.